Chapter 50 will discuss disorders of musculoskeletal function, specifically the rheumatic disorders. So, rheumatic disorders are those that cause arthritis. And arthritis is a descriptive term applied to more than 100 different rheumatic disorders, ranging anywhere from localized, self-limiting conditions to those that are more systemic and autoimmune. All of these conditions share inflammation of the joint as their prominent or an accompanying symptom. So we're going to focus on a few of these in this presentation. Of course, we're not going to focus on 100 different um, rheumatic disorders, but some of the kind of more common diseases that we see that affect the joints. So, systemic autoimmune rheumatic diseases are a group of chronic disorders that are characterized by this diffuse inflammatory lesions and degenerative changes in the connective tissue. So, some examples of the systemic, meaning system-wide autoimmune rheumatic disorders are rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis scleroderma, polymyositis, and dermatomyositis. And the reason we have rheumatoid and systemic lupus highlighted is because those are the two types of rheumatic diseases that we're going to focus on in this discussion. So we're going to start with rheumatoid arthritis. Rheumatoid arthritis, or RA, is a systemic inflammatory disease. It affects about 1 to 2% of the population. Females are affected 3 times more frequently than men. It can occur in all ages, but its prevalence does increase with age, although we do see juvenile cases of this as well. The pathogenesis of RA is an aberrant or abnormal immune response that leads to synovial inflammation, so inflammation of the area within the joints, and then eventual destruction of the overall architecture or makeup of the joint itself. Because this process at the joint is inflammatory in nature, you see signs, outward signs, or clinical manifestations in the joints of people affected, like heat and redness and swelling. Um, the etiology suggested is that it's initially initiated by some kind of genetic predisposition, and then activation of T cell mediated responses to some immunological trigger, such as like a microbial agent. We haven't talked too much about immune system yet. We'll talk about that kind of coming up here shortly. But T cells are a type of immune cell. And in the case of RA, these T cells are kind of turned on to start attacking an individual's joints, causing kind of overall destruction. So some characteristics of rheumatoid arthritis that you can see here. So it's associated with extra-articular as well as articular manifestations, meaning clinical manifestations seen both at the joint and in other areas of the body, meaning that's what extra-articular refers to. Onset of RA, it's usually what we call insidious in nature, meaning kind of slow and steady onset. When we talk about some of the acute types of inflammation later, like gout, their onset is very rapid, right? You go from a normal joint to waking up with something very inflamed and painful. That's not what we see in RA. It's really this kind of progressive change. Um, the insidious onset is marked by systemic manifestations, so things like fatigue, loss of appetite, which is what anorexia means, weight loss, and kind of just a generalized achiness and stiffness. Another characteristic of RA are exacerbations and remissions, meaning these people will have times where the joint pain and inflammation is more severe, followed by periods where they feel pretty good, where there's more of a remission in symptoms. Um, they may have joint involvement that is brief in duration, or it may become more kind of relentless or progressive and debilitating. And so you can kind of see in the picture here a lot of the other sort of extra articular manifestations as well as articular manifestations. So some other things that we see here, lymphadenopathy or uh, involvement of the lymph tissue. You can see lesions in the eye. You can see enlargement of the spleen. You can see things in other organs like pleural effusions, which is fluid buildup around the lungs, pericarditis, which is inflammation of the lining of exterior lining of the heart. You can see nephropathy or inflammation of the nephrons within the kidney. So a lot of different kind of clinical, or excuse me, systemic manifestations involved in addition to those joint changes that we see highlighted here. So a little bit more about the joint manifestations of RA. Um, Usually the joint manifestations are symmetric and polyarticular. And what that means is that usually we see inflammation in bilateral joints, so both knees, or um, inflammation of joints within both hands. We kind of contrast that to osteoarthritis, which we'll talk about in a moment, where we often see the joint manifestations happening maybe in one joint initially. Um, so these are ways to kind of set RA's presentation apart from some of the presentations of things like osteoarthritis. Initially, there's significant limitation of movement, usually caused by pain, but as the disease progresses and there is more damage to the joint itself, that limitation of movement can be happening based on fibrosis. You can see in the picture in the inset there, that's kind of the destruction of that joint by fibrosis that eventually happens, and we lose that articular cartilage, and then can start to lose periarticular or around the joint bone loss. Usually the initial manifestations of RA are seen in the fingers, in the hands, in the wrist, often in the knees or maybe in the feet. That's a little different than osteoarthritis as well. A lot of the time what we see in osteoarthritis as far as initial joint manifestations are those that are more weight bearing, because that's more of a wear and tear disorder. So instead of initial involvement in the hands, like we see in rheumatoid, we would see maybe one knee or a hip, somewhere that has, again, more weight bearing nature. The joints may eventually become unstable as we see all that kind of damage and fibrosis to the joint itself. It starts to stretch kind of tendons and ligaments that support the joint themselves. And so we might see things like subluxations or movement of the bones out of the joint, or even dislocations as we lose the kind of overall stability of the joint itself. Knees are also commonly affected in RA. They can become really visibly swollen. And sometimes if you press or push within the knee joint itself, you can almost see kind of displacement of fluid and movement of fluid within that joint itself. A little bit more about the extra articular manifestations of RA. So these are the clinical manifestations that we see outside of the joint. So again, things like fatigue, weakness, loss of appetite, weight loss. We may even see low-grade fever. Elevated ESR, that's erythrocyte sedimentation rate. That is a serum lab marker that shows signs of systemic inflammation. We may see thrombocytosis or anemia. So things like low red blood cell counts are common in patients with RA. They might get vasculitis or inflammation of the vasculature, and that can cause ulcerations. Particularly, we see those in the lower extremities. And if severe enough, it can cause damage to visceral organs if we get inflammation of the blood vessels that supply those organs. There are manifestations that occur in the eyes that can lead to eventual visual impairment, and splenomegaly or enlargement of the spleen and lymph node enlargement are also common extraarticular systemic manifestations. So, diagnosis of rheumatoid arthritis. So, some of the criteria that we use, one is morning stiffness for at least an hour for at least 6 weeks. So, a lot of the diagnosis of RA is based on things like careful history and physical examination, looking for some of these individual criteria. So things like swelling of 3 or more joints for at least 6 weeks. You can see that multiple joint involvement that's characteristic of RA. Swelling particularly of the wrist, of the metacarpal phalangeal or proximal interphalangeal joints for 6 or more weeks. So those are the joints of the hands and fingers. Systemic joint swelling, so overall, many joints involved. Hand rentogenogram changes. That long word simply means changes to the hands seen on X-ray. And my little inset here shows some of those changes to the joints within the hands that we might see. So you can see this overall kind of deformity and maybe even some subluxation here of the joints themselves as they're kind of slipping out of place. So you can see it extensively in this hand. This hand may be a little less extensive, but you can really see maybe those changes in this little pinky finger here on the left side. Um, some other criteria might be rheumatoid nodules. So you can see nodules or bumps at the joints themselves. We also have some serum rheumatoid factors. So RF tests where we can draw blood and look for rheumatoid factor in the serum. The thing about serum rheumatoid factor, though, it is not diagnostic for RA. So not all people with RA will develop serum rheumatoid factor, so we can't use it as a definitive diagnostic test, but it can be useful in differentiating RA from other forms of arthritis. So the treatment goals for people with RA, so overall treatment aims to reduce pain, minimize the stiffness and swelling, and maintain mobility. So the treatment plan usually includes education about the disease and its overall treatment, balancing periods of rest, different types of therapeutic exercise and physical therapy, and also the use of medications. So some medications used here, things like NSAIDs or nonsteroidal anti-inflammatory medications and corticosteroids, and these can work to overall reduce pain and inflammation. The DMARDs have been a very helpful and kind of game-changing medication in the treatment of RA, even to the point where there's been an overall decrease or reduction in the number of joint replacement surgeries being done with those in RA because of the ability of DMARDs to reduce the overall progression of rheumatoid arthritis related joint destruction. You guys will talk more about DMARDs, I think in your pharmacology class if you haven't done so already. But DMARD therapy in treatment of RA, the recommendations are that the introduction of DMARD therapy should be done early in the diagnosis of RA. The reason for this, and to do it before erosive changes start to appear on X-ray, is because RA immune changes are usually more responsive to treatment if that DMARD therapy is started early. The thing to think about with DMARD therapy, though, and again, something you guys will probably talk about in your pharmacology course, is that you do have to balance some of the potential risks of DMARD therapy. The big ones being the risk of overall immunosuppression. So DMARDs will suppress inflammation and immune response, similar to what corticosteroids would do. So they do make someone overall immunocompromised typically. So we do have to make sure that we're not, immunocompromising someone too much, or that they don't have other reasons that immunotherapy would be contraindicated. Okay, so we're going to switch from RA over to another systemic rheumatoid disorder called systemic lupus erythematous, or SLE. So SLE is a chronic inflammatory disease that can affect virtually any organ system in the body. This includes the musculoskeletal system. Um, the cause is unknown, but what we see is the development of what we call autoantibodies, usually resulting from a combination of factors that would be maybe genetic and hormonal, immunologic, and environmental. SLE, just like RA, is far more common in women. The vast majority of people who experience SLE are females. And so this suggests that it may be related to some sort of imbalance of sex hormone levels. Some of the environmental factors that have been suggested with the development of SLE include things like UV light exposure, different chemicals like drugs or hair dyes, chemicals found in foods, or maybe even infectious agents. So again, we see this formation of autoantibodies and immune complexes. So this is another autoimmune disorder where we see immune destruction of different organ systems within the body. It seems to be related to some sort of B cell hyperreactivity. Again, we haven't talked about immune responses too much, but B cells, just like T cells that we talked about in RA, are another component of the immune system. So we don't have T cell overactivation in SLE like we did in RA. Now it's more B cell hyperreactivity. And again, that'll make more sense when we start talking about some of those immune responses. And so essentially what we're seeing is this increased production of autoantibodies against self. So normally our immune system is programmed to only attack non-self cells, so not our own cells. But in the case of things like SLE, those antibodies start to attack self cells of the tissues and organs. So, a name that we often use for SLE is the great imitator. And the reason we call it that is because it has so many wide-ranging effects on so many different body systems that it can be confused for a lot of different disorders. The onset of SLE may be acute, so pretty sudden, or it may be insidious, so slow and gradual. And the overall course of the disease, just like RA, is characterized by what we call exacerbations and remissions, meaning times where the disease is really flared up, and then times where people experience relatively low levels of overall clinical manifestations. Arthralgias and arthritis, so joint pain and stiffness, are the most commonly occurring early symptoms of SLE. But the polyarthritis, meaning, multiple joint inflammation of SLE, can initially be confused for other forms of arthritis, especially things like RA, because of the similar symmetric and multiple joint pain and inflammation that we see in both conditions. But usually if we do an X-ray or radiologic examinations, we don't usually see the same level of articular or joint destruction that we see in things like RA. So that's one way we can set apart the joint pain and inflammation that we see in SLE versus things that we see in RA. Okay. There's also a lot of dermatological or skin clinical manifestations that we see in SLE. One of them is something that we call the classic butterfly rash, and you can kind of see that on the picture here, but kind of spread across the cheeks and the bridge of the nose, you'll see this classic butterfly-shaped rash that's very common to patients in SLE. Other skin changes, they might develop hives or different cyanotic or purplish discolorations. Hair loss can be common, and things like sun sensitivity. Other things we see, maybe oral ulcerations as well, commonly associated with SLE. Renal involvement or involvement of the kidneys is seen in about 50% of patients with SLE. We'll talk about it a little bit more when we get to kidneys because SLE can cause a condition called glomerulonephritis, which is inflammation of the glomeruli. And in some cases, this can be so severe that it can eventually cause end-stage renal disease or kidney failure in patients with SLE. There's also pulmonary involvement, and it usually involves something called pleural effusions or pleuritis. So surrounding your lungs themselves, there's kind of something called the pleural sac. It kind of holds a fibrotic or a thick fibrous sac that encloses the lungs. And in people with SLE, that tissue becomes inflamed. And there's also kind of a space between the pleural sac and the lung tissue itself. And that usually has fluid inside of it that's designed to kind of to reduce the friction as the lungs move within that pleural sac. And in pleural effusions, there is excess of fluid buildup within that space. These pleural effusions and pleuritis are often associated with kind of overall inflammatory diseases. But what that ends up doing is it either causes pain or difficulty when the lungs kind of move in and out of that pleural, around inside that pleural sac. And if you get extensive pleural effusion or extensive buildup of fluid around the lungs, it reduces the amount of expansion in the lungs. So our patient might become short of breath. They might have things like chest pain. We'll talk in 2015 about something called a pleural rub, which is a sound you can hear in your stethoscope. If we have a lot of inflammation, what you're hearing is kind of like this squeaking noise as the lungs sort of move around with that inflamed pleural sac. Let's see, cardiovascular, similar to pulmonary involvement, is usually pericarditis and pleural, or that should say, be pericardial infusions. So pericarditis and pericardial effusions. Similar to the lungs, there's a kind of a fibrous sac that encloses the heart as well. So same thing, there's fluid in there that can increase when inflamed, that will kind of constrict the heart, or you can get inflammation of the pericardium itself, which causes chest pain and kind of compression of the heart muscle. CNS or central nervous system symptoms. So some patients experience seizure, especially those who are also experiencing renal failure. There might also be what we term psychotic symptoms, including things like depression or unnatural euphoria. We may see decreases in overall cognitive functioning, confusion, altered level of consciousness may even occur. So diagnosis and treatment of SLE, because of, again, that kind of great imitator nature of SLE, its diagnosis can be complicated and difficult. And there's really no one single test that can diagnose SLE in all people. The most common laboratory test performed is the immunofluorescence test or the ANA test. 95% of people with SLE have high ANA levels, but in a similar way to many of the other kind of serum markers we've talked about in other diseases, this test is not specific for SLE, meaning that we will see positive ANA results in healthy people who do not have SLE because it's associated with a lot of other disorders. So again, we can't use it in isolation to definitively diagnose SLE because it's just not specific to that disorder. So overall treatment of SLE focuses on managing the acute and chronic symptoms of the disease. So the goals of treatment include preventing progressive loss of organ function, reducing the amount of exacerbations or flare-ups people experience, and minimizing disability from the disease process, and preventing overall complications of medication therapy. So treatment with medications may be as simple as drugs to reduce inflammation, like NSAIDs, and more kind of mild types of SLE. NSAIDs can also help to control systemic manifestations like fever and arthritis and things like mild pleuritis. There are also some drugs initially used to treat malaria that can be used to treat some of the cutaneous or skin involvement or musculoskeletal manifestations. We also use corticosteroids to treat more significant symptoms of SLE, such as some of the more severe renal or CNS disorders. And finally, immunosuppressive drugs can be used to treat more severe cases of SLE. Okay, so we're going to move on now to osteoarthritis. And osteoarthritis is a degenerative joint disease, but it differs from the last two joint diseases that we were discussing because it is not a systemic disease. So it's more local. So what we're seeing is just local destruction of the joints themselves. So we don't see, like we saw in RA and SLE, all of these sort of systemic clinical manifestations. This is solely a manifestation at the level of the joint. So osteoarthritis is the most prevalent form of arthritis and is a leading cause of disability and pain in older adults. There are both primary and secondary variants of osteoarthritis. Primary variants of OA occur as a result of intrinsic defects in the articular cartilage. So these are just things that, and we'll talk about the pathogenesis, but these are just intrinsic or inborn um, things that are causing destruction to the cartilage itself, as opposed to secondary OA, which has as a known cause. So it might be a congenital defect of the joint itself. It might be trauma or repeated injury to the joint, such as things like dislocations or joint trauma. It could be things like metabolic disorders or some other inflammatory related diseases. So, some risk factors and pathogenesis of OA. So, starting with risk factors, I have age, gender, and race. So, 85% of people with osteoarthritis are in their 70s or older. So, this is very closely associated with age. It is called the wear and tear arthritis. So, it makes sense that those who are older and have had more wear and tear at the joint would experience more osteoarthritic symptoms. Men are more commonly affected than women at younger ages, such as around 45 years. But by the ages of 55, females become more frequently affected by OA. A lot of the time, what we see with women is at that onset of menopause, we start to see more symptoms with many diseases that are more closely associated to the kind of rates we see in men. There are also hereditary influences. Especially people who get osteoarthritis of the hands or in the hip joints. There's often hereditary involvement in that, meaning people with family history of osteoarthritis are more likely to develop osteoarthritis of their own. Let's see, hand osteoarthritis is more common in Caucasian women. Knee osteoarthritis, more common in African American females. There is, again, variation that we see among races. For instance, in your reading, it does talk about people of Chinese descent are the least likely to develop OA. But some of those racial variations that we see may also be associated with things like occupations and levels of obesity. One major risk factor for the development of OA is also obesity. So those as people's weight increases, so does their risk of developing osteoarthritis, especially in weight-bearing joints, again, like the knees and in the hips. So the pathogenesis of osteoarthritis, just kind of very sort of simply. So the articular cartilage and the synovial fluid, both of which are around in the joints, they are designed to provide this smooth, weight-bearing surface with low friction that helps to absorb energy. And just like bone, remember we talked about in bone that there is kind of this constant process of remodeling going on within bone of adults. It's not tissue that's what we call static in nature. You don't develop cartilage and it never changes over your lifetime. You're constantly remodeling, and those cells in the cartilage are undergoing turnover, just like bone. And the cells that control this cartilage turnover are chondrocytes. And over time, as cartilage becomes injured, the chondrocytes also sustain injury. And this starts to affect their ability to repair any damaged cartilage. And so cartilaginous damage, we don't see that same level of turnover and repair over time that we did when people are younger. And so then without that same ability to repair, that articular cartilage starts to erode and starts to expose the bony surfaces. Sometimes you'll have people with arthritis tell you, oh, I'm bone on bone in there. And that's what they're talking about, is all of that cartilage that is meant to cushion and provide that smooth weight-bearing surface has started to wear away and become injured. We haven't been able to replace any of that because of damage to chondrocytes. And now the two bones in that joint are starting to kind of rub together. We also have synovial membranes within the joint, and they start to sustain trauma and become inflamed. So just like in RA, we do see joint inflammation in OA, but it's not as pronounced and it doesn't happen initially like we see in RA. It's something that happens later on once we start to get more damage and trauma. Okay. And so you can see in my little picture here too, that erosion, the cartilage and the bone are starting to erode at that joint space. And this also causes this kind of overall narrowing of that joint space itself. So the manifestations of OA, usually more insidious in nature. So meaning slow and steady onset. So initially there's pain at the joint that usually feels like aching. And sometimes it's even difficult to localize initially. And it usually worsens, the pain usually worsens with activity or use and is relieved by rest. So remember with RA folks, they were kind of waking up and stiffness throughout the morning, little different presentation with OA. In later stages of the disease, activity and night pain start to happen and are experienced even during rest. So that is more of a sign of progression of OA. Okay. We also may see clinical manifestations of what we call crepitus or grinding when the joint is moved. And then as the disease progresses even more, even minimal activity can cause pain because the range of motion within the joint itself has become so compromised by the destruction of that articular space. So again, manifestations like joint pain, that's really progressive in nature, stiffness and limitation of mobility that are progressive in nature. Over time, as that joint becomes more damaged, we might see instability and deformity. So diagnosis and treatment of OA. Diagnosis is primarily accomplished through history and physical examination and X-ray findings. We also may do labs to exclude other diseases, so try to exclude things like RA. I have a picture of an X-ray of a joint here. You can see normal is on the left, and what you should cue in on is the size of that joint space. You can see in my OA patient how that joint space has started to shrink. How, because we're losing that cartilage within the joint itself, the ends of those bones start to come closer together. So that's really indicative of OA. There is no cure for osteoarthritis. Treatment is aimed at reducing symptoms and maintaining overall mobility. So some of this might look like physical rehabilitation or physical measures that are aimed at improving maybe the supporting structures of the joint. So strengthening some of the opposing muscle groups that might help to cushion the weight-bearing forces. So again, as we lose the weight-bearing force kind of absorption that we normally get from the cartilage, physical rehabilitation measures might aim to try to replace some of that with increase of muscle around the joint. But we do need to kind of balance rest with exercise to reduce pain. We may also use measures like splinting of the joint, things like heat or cold, and then overall weight reduction in our patients may help to ease the symptoms of OA. We can use anti-inflammatory treatments here as well, things like NSAIDs, or steroid injections directly into the affected joint may help to reduce pain and inflammation. And then there are surgical procedures. So things like joint replacement or arthroscopic lavage that we use to kind of clear out like maybe any bone spurs or any kind of debris that might develop at the joint. Um, Things like bunion resections, osteomies to realign knee and hip joints. If there's arthritis in the spine, maybe decompression um, of those spinal roots. So just some examples of surgery. But I think the most common surgical treatment we associate with osteoarthritis are things like joint replacement surgeries, where we replace that damaged cartilage with some sort of prosthetic joint. All right, so now we're going to move on from that discussion of osteoarthritis to some of the metabolic and endocrine diseases associated with joint symptoms. So there are a lot of diseases, as you can see here, that can lead to symptoms of the joints themselves. So amyloidosis, gout, osteogenesis imperfecta, which we talked about already, diabetes, hyperparathyroidism, thyroid disease, AIDS, and different hypermobility syndromes. So we've discussed, as I said, OI already. We've discussed some of the endocrine disorders. So for this discussion of the metabolic diseases, I'm actually just going to focus on the metabolic disease of gout. So gout is actually a group of disorders that are characterized by increased levels of serum uric acid, which eventually leads to these urate crystal deposits in both the kidneys and in the joints. So in the little picture I have here, this is the big toe joint, and you can see it has become swollen and inflamed because this uric acid that had been building up in the serum started to accumulate itself and crystallize within that joint space itself. And this causes pain and inflammation associated with gout. So acute gouty arthritis with recurrent attacks of severe articular and pre-articular inflammation are characteristic of gout syndrome. Okay. Over time, you can get something called a tophi, which is the accumulation of these crystalline deposits in the articular joint surfaces in the bone. You can also see them develop in the soft tissues and in the cartilage. I didn't put any pictures in here, but if you Google tophi, you'll see some pretty um, gnarly looking little pictures of all these sort of almost like tumor looking like deposits either under the skin or at the joints themselves that cause a lot of deformity in these patients. We can also get gouty nephropathy or renal impairment. So again, these uric acid accumulation can also occur in the kidneys. And if we have patients who have hyperuricemia or increased uric acid levels in the body, they can also develop kidney stones because of that uric acid accumulation. And we'll talk about that more when we get to the renal diseases. So gout is more prevalent in males, so 70% of cases happen in men, and even more prominent in males of African American descent. Peak age of gout occurrence is usually between the ages of 40 and 50. And again, associated with high uric acid levels or what we call hyperuricemia. That's present in about 5 to 10% of the population in the United States has this, but not everybody develops gout. Many people just live with what we call asymptomatic hyperuricemia. So that's just a laboratory finding. It's not necessarily a disease. But 1 in 5 people with hyperuricemia will eventually develop gout. But most people who have it don't. So just because hyperuricemia is present doesn't mean someone will develop gout. So we have 2 types, primary and secondary gout. Primary gout, these designate cases in which the cause of the disorder is unknown or there's some inborn error in the metabolism of uric acid itself. So these are characterized primarily by hyperuricemia and the development of gout. Secondary gout is something where we have a cause of hyperuricemia that's known. But the gout is not the main disorder. So in primary gout, that's the main disorder these people are suffering from. They have hyperuricemia that leads to these acute gout attacks in the joint. In secondary gout, they may have gout attacks, but there's some kind of other more significant, probably disease process that's going on. So some examples of things that cause secondary gout are kidney disease. So if someone has renal failure, and they also will accumulate uric acid that can eventually lead to gout, but the primary problem is the kidney disease. Another thing is tumor lysis. So patients who are undergoing treatment for things like cancer, like things like I think lymphomas and leukemias, as the treatment starts to break down different like kind of tissues and things within the body, that can cause an accumulation of uric acid as well. So the primary disease is the cancer. The secondary thing that we might see is gout. So the pathogenesis of gout, again, these are elevated serum uric acid levels. Uric acid is an end product of what we call purine metabolism. And so there's a connection between gout and dietary intake as well. So we're going to talk about that in a moment, but when we talk about purine metabolism, it's the breakdown of things in the diet that contain purines. Um, so most commonly, these uric acid level increases that we see in gout are caused by either overproduction of uric acid in the body or inadequate elimination of uric acid by the kidneys. So these are the two main causes of primary gout. And this is 90% of the cases of gout that we see. So the majority of them are associated with these two things. Acute gout occurs when urate crystals start to precipitate in the joint and cause an inflammatory response. Over time, if we have recurrent inflammation, this can start to cause destruction of the cartilage and bone, and eventually development of tophi with multi-joint involvement, again, if left kind of untreated and uncontrolled. So the clinical manifestations with gout really occur in 4 phases. That first phase is the asymptomatic hyperuricemia. As we mentioned before, lots of folks have hyperuricemia, but not all develop gout. So this is really an asymptomatic stage. No gout formation yet, but the kind of underlying problem is there. The second phase is acute gouty arthritis, and we'll talk about that a little bit more, and then intercritical gout, and then finally chronic tophaceous gout. And those last two things, again, happen if we don't control recurrent attacks of acute gouty arthritis. So during an acute attack, some of the clinical manifestations we see, well, one of them is it most commonly attacks in a monoarticular way, meaning one isolated joint. And the most common place that we see joint involvement is in the big toe. Oftentimes the pain of acute attacks begins at night and often following things like extensive exercise or following the administration of certain medications or intake of certain foods or alcohol intake. And both of those things are associated with increased intake of purines, leading to a resultant rise in uric acid levels. There's usually a very abrupt onset of pain with redness and significant swelling at the joint itself. So the objectives for treatment of gout include the termination and prevention of acute attacks of gouty arthritis. So when someone initially presents with gout, our first kind of order of business is to reduce that inflammation. So we can do things like administer NSAIDs for that initial inflammation attack. But then we also have to think about how we will prevent any future attacks, because as we discussed, if this is uncontrolled, it can lead to further progression that can lead to kind of permanent damage of the joint itself. So when we're talking about prevention, one thing that we need to think about is correcting that hyperuricemia to prevent attacks in the future. Um, so things that we can do to correct hyperuricemia. Um, Usually we initiate treatments to prevent hyperuricemia once that inflammation that we see initially has subsided. So we can use different medications here. So one is urosuric agents, and those are medications that you guys will talk about in your pharmacology class, but they aim to prevent the tubular reabsorption of urates. So at the level of the kidney, instead of allowing the kidney to reabsorb or pull urates back into the bloodstream, it would these medications will encourage an increase in excretion of urates at the level of the kidney, to prevent the buildup of them in the serum. And there are also medications that can help to inhibit the overall production of uric acid. So those are things that patients with acute attacks may take more prophylactically or long term to prevent future attacks. Another way that we try to correct hyperuricemia is by encouraging lifestyle changes, such as reducing alcohol intake, not smoking, avoiding purine-rich foods. So I have a little picture here of things that are included in that purine-rich foods. So worst foods for gout, so things that contain high fructose corn syrups, beer and alcohol, shellfish, shrimp, and anchovies, or any game meats, red meats, especially organ meats, contain a lot of purines as well. So these are things that people might need to reduce or eliminate from their diet to prevent acute gout attacks.